that you're looking for kind of right there, if I find that soft spot, that's kind of the interior portion of the joint line, and then I just work around. So if I'm finding the spot there, then I can just work back, and while I'm working back, I should stay right in that little ridge. And if I stay in that ridge, that's the joint line. So that's going to be where we have joint line tenderness, meaning possibly arthritis or possibly a meniscal involvement, all right? When I get kind of far back here, kind of disappears. I get kind of over the hamstring, more tissue. I don't really feel, doesn't mean I can't palpate that area. It's just not as clear that I'm right on the joint. So in that case, I'm just working back, and I just kind of keep working back my imaginary line that it is, okay? Now I put MCL on there. The MCL and the LCL are right kind of on the right on the joint, kind of right in the middle, right? So the little spring kind of indicates it there. So if my problem is, if I feel tenderness up here, that's clearly not the MCL, right? But if I'm right over the outside edge here, you can consider possibly an MCL problem. Again, MCLs usually don't become an issue unless there's some kind of trauma. So again, you'd have to fit the subjective reports. Hey, I got kicked on the outside of my knee, or someone fell on the outside of my knee went in, and now I'm real tender right here. It doesn't mean for sure it's an MCL. Again, we would do valgus testing later and kind of confirm with that, all right? So we got our joint line kind of up from your joint line. So part of your joint line is the femoral condyle. So all of this area here is. You can really feel that circular point though if you come right up like so. That's going to eventually create the trochlear groove where the patella runs in. So that's the femoral condyle right there, and it kind of comes around like that. So the femoral condyle medial is just the proximal side of the joint. Lateral is just the, again, proximal side of the joint laterally. So that's the medial joint line and the medial femoral condyle. Pezan serine and tibial tubercle. Again, the pezan serine is more of an area. You don't really feel. Huh?
Did you say proximal?
Proximal, yep. The femur is the proximal side of the joint. Tibia is the distal side of the joint. Pezan serine is more like an area. So again, it's generally not something that you feel unless it's tender. Again, I go to that same spot, and the only reason I go to that same spot is I need to go down. It's going to be down like this, all right? And some tenderness in that area indicating possibly bursitis, all right? So again, find the joint line, and we're going down. So it's medial to the tibial tubercle, all right? Probably medial and a little bit superior to the tibial tubercle, right in there, but clearly not the joint line. If you're at the joint line, then that's why I usually leave my one finger on the joint line to make sure I'm not on the joint line when I'm palpating the pezan serine, okay? And again, it's not something you feel. It's just like this out here. I don't feel her greater trochanteric bursa. I just push and it hurts. I just push and it's tender. That's my sensation. That's the concept of, okay, you have tenderness over the pezan serine bursa, right? So it's not something you're really feeling like the distal bicep tendon is an example of something we can flip across. We know we're on the tendon. This, we don't really know. We're kind of palpating an area to see if it's tender. Tibiotubercle is a spot on the tibia where the quadricep inserts, right? So it should be easy to feel, a little bit of a bony prominence there. That's the tibial tubercle. Sometimes tibial tuberosity, people say. Patella tendon, again, we really have two options here. Sometimes they refer to this as the superior patella tendon and the inferior patella tendon, okay? Sometimes people refer to this as the patella tendon and this is the patella ligament because technically here it's going from bone patella to bone tibial tuberosity, all right? So sometimes there's a couple of ways we can name it, I guess, as long as you're just consistent. So superior patella tendon, inferior patella tendon, all right? It should be something that's easy to, you can kind of, if I come in from the sides to get where my joint lines is, my joint lines are, I should really be able to get the patella tendon. It's right between my fingers there. So moving it side to side, cross-frictioning sides, it should be very easy. Now again, you want to make sure you go all the way up to the patella and all the way down to the tibial tuberosity because usually where the tenderness is not mid-substance, but at insertion points. So you want to make sure we go all the way up. Slide back and lay on your back. The patella has a medial and lateral border. it's important to kind of be able to find those. Often I'll put my fingers and kind of just do a little bit of mobilization to make sure that the border's not kind of stuck down where I can't see it. Same thing around the apex is the tip and the base at the top. So again, I will push up at the base to make sure the apex, I'm actually on it and it's not kind of hiding down in the bursa there. So I'm just making sure my parameters are normal there. Now what we're going to do here, we'll talk a little bit about patella orientation. So in this case, if I were to look from her feet and I take my fingers on her medial lateral border, you should hopefully see that my fingers are pretty parallel like that. If they were to be like this, we would call that a lateral tilt. That's kind of some of that terminology that I said Jenny McConnell kind of came up with. And again, so basically if you look at her patella, if it were like this, that would be a lateral tilt. So if that were the case, my treatment is simply take my hand on the medial portion of the patella and do medial tilting, right? That would stretch these structures out here, right? Or if either by alignment or by an x-ray, she has a lateral glide, what that means is instead of being equidistant here, I'm out into this position. So instead of being kind of in the center of the trochlear groove, it's positioned out here. In that case, the treatment is to do what's called a medial glide. So I'm just moving her kneecap in, right? If all of her pain is down here at the patella tendon, which we just palpated, I might think, is their apex kind of going down in? So does she have what's called an inferior tilt? So my treatment might be to get on the top half of her patella and kind of pop that apex out of there, all right? That would be your treatment from a taping perspective as well. So again, if my patella is here and I wanted to tape, and if I'm tilted, I just put the tape on the medial half and pull it down. So it basically does what my hand is doing, right? If it's lateral glide, I just hook it on the edge and pull it in. If it's inferior, I just put the tape across the top half to pull it down. So the tape is just doing what you see with your hands and what you do with your hands to correct it. And then hopefully it stays that way when they walk out because you can't hold it there for them when they walk out, right? So hopefully the tape is doing that, all right? So we got some orientations. We usually call it medial lateral tilt, medial or lateral glide, inferior tilt. There's also an internal and external rotation. People don't mess with that one as much, but there is a rotation component as well. So let's palpate all of those things.